Greetings and welcome to the Multiple Myeloma Highlights from the 2015 American Society of Clinical Oncology Annual Meeting and 20th Congress of the European Hematology Association Telephone and Web Education Program.
Greetings, everyone. This is Ann Quinn Young from the Multiple Myeloma Research Foundation, and I'm so pleased to welcome you to this telephone and web education program that's intended for patients and their caregivers, but certainly open to anyone who'd like to participate. The 2015 ASCO annual meeting and the 20th Congress of the European Hematology Association, or EHA, ended about a month ago. Our faculty today was there on site and is here to discuss the latest information that was presented during those meetings. I'd first like to acknowledge Onyx Pharmaceuticals, an Amgen subsidiary, Bristol Myers Squibb, Takeda Oncology, and Genentech for funding this very important program, and also to thank them for their understanding of the continued need for up-to-date information for patients and caregivers, particularly when there's important data coming out of meetings like ASCO and EHA. As many of you know, the MMRF was founded in 1998, and we are the #1 private funder of myeloma research worldwide. Our sole focus is on accelerating new treatments to extend and improve the lives of patients and ultimately find a cure. Together with our affiliate organization, the Multiple Myeloma Research Consortium, or MMRC, within which we work very closely with both Dr. Wolf and Dr. Kumar, we've helped support the development of more than 70 different therapeutic approaches. And through the work of the MMRC and all of our partners, we've launched more than 60 different clinical trials of more than 30 different agents. We also have 2 gateways. You might have heard about one during the recording as you were waiting for the call to begin. One for researchers, one for patients, and their sole purpose is to accelerate precision medicine in multiple myeloma. The first one, the Researcher Gateway, allows researchers worldwide to view and analyze clinical and genomic data from the MMRF COMPASS study. The MMRF Community Gateway allows patients to access information, connections, and clinical trials that are specific to their type of disease. We also offer a lot of educational programming for the entire myeloma community, from live programs, online programs, print programs for patients, caregivers, and also healthcare providers. You can find much of this information on our website at www.multiplemyeloma.org, and keep coming back because we often post new information about the disease and its treatments and information on upcoming educational programs. As you heard today, our esteemed presenters today are Dr. Shaji Kumar from the Mayo Clinic in Rochester, Minnesota, and Dr. Jeff Wolf from the University of California, San Francisco. Again, 2 of our most valued partners and 2 individuals who have been highly engaged with the Foundation for many years. Dr. Wolf will start and provide an overview of data related to approved treatments presented at these meetings, as well as an update on data for the treatment of smoldering myeloma, which has become a rapidly evolving field. Dr. Kumar will then provide perspectives on new treatments for both newly diagnosed and relapsed refractory myeloma, those treatments that are in clinical trials or just approved by the FDA. Afterwards, we'll open the program up for questions for both telephone and web participants. I'm pleased to see a number of folks have already submitted some questions on the web, so keep submitting throughout the programs as questions come to mind. We also send an email reminder to everyone registered for the teleconference, and that includes a link to a program evaluation. We strongly encourage you to complete that evaluation after the program because it helps us plan for future programs and continue to make improvements. It is now my pleasure to hand it over to Dr. Jeffrey Wolf.
Thank you so much, Ann. On the first slide, you can see the progress we've made in myeloma, which has been tremendous over the last 50 or 60 years. You can see in the 1960 to 70 decade, the average patient with myeloma only lived about 2 years. If you look at the line that's at the top, that indicates that many of our patients are living beyond 6 or 8 years, and the median is going up every year. Progress has been made with many small steps, a number of new drugs and combinations, and then putting combinations together successfully with other combinations. So it's not that we have just one drug that makes all the difference in myeloma, but the little steps that I mentioned. In the second slide, you'll see the spectrum of plasma cell problems that range from MGUS, monoclonal gammopathy with undetermined significance, through smoldering myeloma to symptomatic myeloma, the kind of myeloma we generally treat. And in that slide, you can see that the definition of MGUS is essentially a small amount of protein, a small number of plasma cells in the bone marrow, and no end organ problem, that is, no bone problems or kidney problems. Almost everybody with myeloma starts with an MGUS and progresses over the years to smoldering myeloma, for example, the next box in which you see that there are more plasma cells in the bone marrow, but still no evidence of damage to any organs. Finally, symptomatic myeloma is a situation in which there is already damage to organs, and these patients obviously need treatment. Over the years, you can see in the next slide, we have defined those end organ problems using the acronym CRAB, C-R-A-B, which stood for an elevated calcium level in the blood, kidney problems, anemia, and bone lesions. But we have now increased the number of problems that make patients what we call symptomatic and deserving of treatment. And some of that trend has been to treat patients before they have these end organ problems. Obviously, we don't want to wait for damage. We want to try to preempt and treat earlier. We now define patients who need treatment to include those who have plasma cells more than 60% in their bone marrow, to have a light chain ratio, either kappa to lambda or lambda to kappa, of over 100, and using better imaging than just plain X-rays that were available maybe 100 years ago to Madame Curie. We now are using MRI scanning, and if a patient has more than one plasmacytoma or focal lesion, then that also defines them as having symptomatic myeloma and worthy of therapy. And that has happened in just the last year or so. The average patient with myeloma will have an asymptomatic period, as you can see on the left in this curve, followed by active myeloma and then treatment. And that treatment often results in full control of the disease for a period of time or a plateau in remission. That period of remission is increasing every year as we find better ways to achieve deeper responses. But most patients do relapse, and after relapse they get second-line therapy. And the reason for defining this now is that we will be talking about studies in second-line therapy. And then there's another plateau, perhaps not as deep as the first, although we're hoping in the future to have deeper responses, and then another relapse, and subsequently a third line or a fourth line or a fifth line of therapy. One of the areas of major activity in myeloma now is defining what makes smoldering myeloma more aggressive. That is, how can we predict the patient who has smoldering myeloma but will progress to symptomatic myeloma, because we'd love to treat that patient with smoldering myeloma before they ever become active. There are a number of schemas that look at this, and this is just one of them that was presented by the Spanish group that involves looking at the height of the protein level, the amount of involvement in the bone marrow, and the amount of suppression of the other good guys, the other proteins that are not part of the malignant problem. There are other schema that include, for example, the light chain ratios, and so there is not just one schema, and this is being sorted out, and perhaps ultimately we'll have a combination of all of them that help us predict who with smoldering myeloma needs early treatment before they have problems. In this next slide, we're going to begin to look at some of the treatment studies that were presented in the last few months. This is a study called the FIRST study that involves studying a combination that we don't use much in the United States, that is melphalan, prednisone, and thalidomide, and they compared that combination, 12 cycles of that, to 18 cycles of lenalidomide and dexamethasone, that's Revlimid and dexamethasone, compared to lenalidomide and dexamethasone indefinitely until relapse. And what you could see at the bottom of that slide is that there was not much difference in survival, that is how long patients lived, in the two Revlimid dexamethasone or lenalidomide dexamethasone arms, but they both tend to do better than melphalan, prednisone, and thalidomide. And most doctors in the United States have already made the switch away from melphalan, prednisone, thalidomide to Revlimid and dexamethasone, so this study had more impact in Europe than in the United States. This next study is a study of transplant versus no transplant. And this is a very controversial area in our field. We've been doing autologous, that is using your own stem cell transplants in the United States since the early 90s. And this is one of the major ways in which we've made that improvement that I showed you in the first slide. But the question is, do our newer therapies obviate the need to do a transplant? There is a huge French-American study that will be looking at this question ultimately in the next few years, that is transplant as part of initial therapy versus transplant later. This is a smaller study aimed to look at that question, and in this study, the transplant arm, that's that lower purple arm, is compared to a Cytoxan or cyclophosphamide lenalidomide dexamethasone arm after lenalidomide dexamethasone initial therapy. Now, the CRD, the cyclophosphamide lenalidomide dexamethasone arm, is not a common arm that we use here in the United States, and so that makes this study a little bit flawed. Despite that, if you look at the bottom, the transplant arm does a bit better. That is what's called progression-free survival. The time before the disease comes back again is better for the transplant arm, although there are a lot more side effects, obviously, that come with the transplant. You see that in the next two lines. Ultimately, the answer to this, we hope, will come with the bigger study that will be available in the next few years. The next slide is a study looking at maintenance therapy, or the therapy that we do after transplant, for example. This is an extension of a study that's been reported before. It was a very large study with 461 patients, and this is a follow-up on that study. And as you can see, after transplant, the patients were randomized. That is, half of them got lenalidomide, that's Revlimid, or placebo, and the lenalidomide arm won in terms of time to progression, that is time before the disease came back again, and actually won in terms of overall survival. That is, more patients were alive out there 5 or 6 years if they had the maintenance therapy in a prolonged fashion. Now, I should point out that a similarly structured French study showed the same time to progression, but no benefit in overall survival, so that this continues to be a point of argument in our field and one for major discussion between doctor and patient. It should also be pointed out that the people on the lenalidomide maintenance arm had a higher rate of second cancers. It was not extreme. It didn't totally outweigh the benefit that we saw, but in this study, it was 25 patients who got second cancers versus 10 in the placebo arm. This next study, to make things even more complicated, again, is a transplant question. It is lenalidomide dexamethasone followed either by transplant, that's ASCT, or further lenalidomide and dexamethasone, and then continued lenalidomide and dexamethasone for both groups. And in this study, there was no benefit in progression-free or overall survival. But remember that this is a smaller study, and I think the bigger study that's coming may well answer the question better. You can see that it was only 29 patients in one group and 31 in the other. This was a very exciting presentation at ASCO, and it's one that we're very proud of within the MMRC, the group that's sponsoring this call. And this is a combination of carfilzomib, that's a new drug, sort of next generation Velcade or bortezomib, plus lenalidomide or Revlimid and dexamethasone, followed by transplant using one's own stem cells, followed by continued carfilzomib, Revlimid, dexamethasone for a long, long, long time. And what you can see here, if you look at the bottom of the curve, what's important to us is if you look at the last column, which looks purple to me, you can see more and more and more patients achieve what we call a stringent complete remission, where you can no longer measure the cancer in the blood or even in the bone marrow, and it goes from 8% up to 22% after the transplant, and then 71% with further consolidation or more of this what we call KRD regimen, and then ultimately 87% of patients achieving a stringent CR. Now, there are very few people out there on the right side, only 8, but interestingly, I think on the next slide, of those patients on the far right there who achieve that stringent CR and have gotten all that therapy, when one does a very new technology looking at minimal residual disease, trying to measure even one malignant cell in a million, 100% of those patients had achieved what we're now calling a molecular complete remission. So this is very exciting. The downside is that it's a tremendous amount of therapy. It's years of 3-drug therapy with a transplant thrown in there as well. But it's at least hopeful that maybe we can get there. The next slide is the ASPIRE trial. This was a very important trial. It compared 2-drug regimen, lenalidomide and dexamethasone, to a 3-drug regimen, carfilzomib, lenalidomide, and dexamethasone. And clearly the 3 drugs beat the 2 drugs. And you can see on the bottom, if you look at progression-free survival in both categories, whether somebody had had only 1 prior therapy or 2 or more prior therapies, there was a better progression-free survival. And most importantly to us, the progression-free survival is beginning to set a standard that is the 25.8 months of progression-free survival in patients who had already had 2 or more prior therapies is really quite an advance, and I think that this is, as I said, the new standard. The ENDEAVOR trial, just presented at ASCO last month, compared 2 proteasome inhibitors, the original first-in-class bortezomib to the new carfilzomib with dexamethasone. And something that should be pointed out here is that the carfilzomib dose was doubled over that is generally administered in the community or recommended by the FDA. So it's double-dose carfilzomib versus bortezomib, and the carfilzomib wins if you look at the bottom in terms of overall response rates, in terms of complete remission rates, and in terms of progression-free survival. You see that in the third bullet where it says 18.7 months versus 9.4 months. So the question is, can we double the dose of carfilzomib, do better than bortezomib? The increase in side effects when you double the dose of carfilzomib was mostly high blood pressure, which was managed pretty well. Like I said, I'm out of slides, so I'm out of talk. And I'm going to turn it over to you and Shaji. Thank you.
And really, thank you for setting the stage with that really helpful background information on the disease, which I think provided really helpful context to the data that you presented. Before we go on to Dr. Kumar, I want to emphasize a few points that Dr. Wolf mentioned in his presentation. First, there really was no data presented on trials in smoldering multiple myeloma, but it's important to let everyone on the call know, if you don't know, particularly if you are smoldering, that there are now trials underway. Just recently within the MMRC, we opened one with daratumumab that you'll hear more about from Dr. Kumar in a minute, and you can find out more about that on myelomatrials.org or by calling our patient support center. In the past, treatments really were deemed too toxic, or there were limited treatments available, so the risks of treating smoldering myeloma seem to outweigh the potential benefits, but all of that is changing. Another important point that Dr. Wolf mentioned a couple of times is that the data indicate, autologous stem cell transplant is still an important part of therapy, but the data really are needed for the longer studies to help us better understand the benefits or lack thereof versus continuous drug treatment. Similarly, the data do seem to confirm that Revlimid maintenance post-transplant is beneficial for most patients, and at least in terms of time to progression. As you heard, the data are a little bit inconsistent in terms of overall benefit, but again, some of these larger studies, even studies like our own COMPASS study, should help elucidate, again, which patients are most likely to benefit from prolonged maintenance therapy. And then finally, at the end of the presentation, you heard about how new drugs like Kyprolis are getting moved up in the disease course. Kyprolis was first approved in relapsed refractory patients who had been through pretty much every treatment available. Now it's approved in first relapse, and we're seeing really exciting data, the ASPIRE trial, unprecedented progression-free survival in relapsed refractory patients, and then really promising early data from our own MMRC trial, combining it upfront with RevDex. So not only are we seeing new treatments come to the disease, but we're figuring out how to optimize the treatments that we have available. So with that said, it's my pleasure now to introduce Dr. Shaji Kumar.
Thank you, and Dr. Wolf gave a really nice overview of where things are. And what I would like to do is to kind of take off from there and talk about what is on the horizon. We know definitely the outcomes, the survival of patients with myeloma is continuing to improve. and the future is going to depend on all the ability to introduce new drugs that work in different ways, and also drugs that can be combined to create very effective regimens. And obviously, the long-term goal is to try and make this disease go away, but until that happens, we continue to need new therapies to keep the disease under control. So I'm going to first start off by talking about a drug that was recently approved for treatment of multiple myeloma, that is Panobinostat. Now, the results of the trial have been presented and has also been published since then. And this is large phase 3 trial that looked at the combination of Panobinostat or Feridac with bortezomib in patients with myeloma that have relapsed after prior treatments. And patients who have had at least 2 prior treatments were included in this trial. And they were able to show that the addition of Panobinostat to the bortezomib dexamethasone combination clearly improved the progression-free survival in patients with relapsed myeloma. Now, this benefit was particularly relevant in people who had seen both bortezomib as well as other immunomodulatory drugs like Revlimid or Lenalidomide and thalidomide. And there were clearly patients in the treatment group, which is the group who received the Panobinostat, who had more deep responses, like the complete response and very good partial response. And this translated into an improvement in the progression-free survival. The trial so far does not show any differences in the overall survival, but again, I think the trial basically highlights the fact that when you add Panobinostat to the bortezomib dexamethasone, we clearly see some impact on the myeloma. Now, this has led to several clinical trials that are currently ongoing. Now, one of the advantages of the Panobinostat is a pill, so that clearly makes it much more easier than something that has to be given intravenously. However, it is also associated with some side effects, especially gastrointestinal side effects, diarrhea being one of the most common side effects that has been seen. The currently ongoing trials are looking at, can we actually combine the Panobinostat with other proteasome inhibitors? You already heard about Kyprolis or carfilzomib. That seems to be working very well when combined with other drugs like Revlimid or Lenalidomide. It is also being studied in combination with Lenalidomide to see if we can have a combination that is completely oral but still harnesses the efficacy of that particular class of drug. Now, we'll talk more about this class of drug as we talk about other new drugs, but the whole class of histone deacetylase inhibitors is certainly a very exciting area of clinical trials at this time. Moving on to the other trials that were presented, I specifically want to highlight the new class of drugs that's coming along, that's the monoclonal antibodies. Now, this is particularly exciting because a monoclonal antibody called rituximab clearly changed the treatment paradigm in patients with lymphoma. And we are hoping that we can kind of recreate history here by using monoclonal antibodies in patients with myeloma and get really good efficacy. Now, the ELOQUENT trial, this is a large phase 3 trial that looked at a monoclonal antibody called elotuzumab. Now, this is a monoclonal antibody that's directed against a protein that's present in on the surface of most of myeloma cells. Now, the initial trials that were done looking at the combination of elotuzumab, lenalidomide, and dexamethasone showed that the disease remained under control for several years in patients who had not previously seen or been treated with lenalidomide. Now, those results were very encouraging and led to the design of this phase 3 trial, where they basically had a little over 600 patients with myeloma who had 1 to 3 previous treatments, but had very little exposure to lenalidomide. And these patients were basically randomized to getting either the lenalidomide and dexamethasone or those 2 drugs in combination with the monoclonal antibodies. And what they were able to see was that the addition of the monoclonal antibodies clearly improved the time the myeloma stayed away, the progression-free survival, by about 5 to 6 months. And the addition of the antibody clearly led to deeper responses and more number of patients actually being able to get a response or disease control compared to just lenalidomide and dexamethasone. So the trial clearly shows that this monoclonal antibody has activity in myeloma, that it is able to control the disease and for a good amount of time. So this monoclonal antibody is currently being studied in other contexts as well, especially in the newly diagnosed setting where there is an ongoing trial that is looking at the same kind of comparison. Is the monoclonal antibody in combination with lenalidomide dexamethasone better than just using lenalidomide and dexamethasone? So hopefully we will have more data in the coming years, and we anticipate that this drug would also be approved in the near future for treatment of myeloma. Now, the other monoclonal antibody that is also quite exciting is a drug called daratumumab. Now, this and another similar drug called SAR, with the different numbers behind it, that is also going through clinical trials at this time. And both seems to have significant efficacy in controlling multiple myeloma. So the trial that was present at ASCO was a large number of patients, 106 patients, who had 1 to 3 previous treatments but had received both the immunomodulatory drugs as well as the proteasome inhibitors like the bortezomib, and a very few patients have also received other more newer drugs. The median number of prior treatments was 5, so obviously a heavily pretreated group of patients. And when these patients received daratumumab as a single drug, it was able to control the disease or have a response in about a third of the patients, and that included about 10% of patients with a very good partial response, meaning at least 90% decrease in their M spike. And this response, when you saw the response in this third of these patients, it lasted for about 7 months. And about 2/3 of these patients were still alive at the end of a year of treatment. So this clinical trial clearly shows that this monoclonal antibody has the ability to control multiple myeloma, and the results are very promising. And there are phase 3 trials that are currently ongoing, both in patients with relapsed disease as well as patients with newly diagnosed myeloma, which will essentially show us that addition of monoclonal antibody to the currently used treatments like lenalidomide and dexamethasone improves the response rate as well as the duration for which the myeloma stays under control. So this is probably one of the most exciting class of drugs that are currently going through clinical trials, and we hope that this particular drug would also be approved very soon. Now, the next slide is actually a list of multiple different new drugs that are currently going through clinical trials. So I'm going to go into details of a few of these. Now, the CAR T cells, now that is a totally new way of trying to treat cancer. And many of you may have heard about the spectacular results that we have seen in patients with leukemia. Now, this is essentially a way of making the T cells, or kind of harvesting the immune system that's already there and making it recognize the cancer and helping us get rid of the cancer. So these T cells are being modified to recognize the cancer cells are being foreign to the body and getting rid of them. Now, Dr. Stedmer from the University of Pennsylvania had presented some data suggesting a very small number of patients, about 5 patients, where they had previously seen a variety of different treatments, and these patients then underwent a second autologous stem cell transplant, and as they were coming off the transplant, they were treated with this CAR T-cell approach. And so far the results are quite intriguing, given what we would have expected based on historical data, how these patients would have done. So I think that is an exciting area that is being explored through multiple clinical trials in different institutions, so I think we'll stay tuned. Now, the Histone Deacetylase inhibitors, we talked about it. Again, that is the same class as the Panobinostat that is recently been approved. But there are newer drugs like the Resolinostat, which is again down the list, which is a more selective Histone Deacetylase inhibitor. We think only one or two of the Histone Deacetylase inhibitors play the major role in myeloma. So if we can target just one of them, we could actually be able to get all the benefit without significant side effects. So the Resolinostat is currently going through clinical trials, and the early results again seems to be quite encouraging. Now, going back up the list, you see something called ixazomib, and also a couple lines down you see oprozomib. Now, both of them are proteasome inhibitors, so they are similar to the bortezomib or the Velcade and the carfilzomib of the Kyprolis we talked about. The distinct advantage of these two drugs being this can be given orally. Now, obviously, compared to having to go into the clinic once or twice a week and getting injections or infusions, being able to take a pill once or twice a week is clearly something that's desirable, especially if these drugs are quite efficacious. Now, ixazomib has been studied alone and in combination with a variety of different drugs, including lenalidomide, and these results look quite promising. And there's a large phase 3 trial that recently finished, and the early results show that adding the ixazomib to lenalidomide and dexamethasone improves the ability to control relapsed myeloma. Oprozomib is a little bit early on. It is going through the very early phases of clinical trials, but the results so far, again, seems quite interesting, so we will be seeing more of these clinical trials coming along. Now, the SAR 6509H4 is a monoclonal antibody similar to the daratumumab. They both target the same protein that's on the surface of the myeloma cell, and the results so far with both seems to be quite encouraging. The SAR drug is a little behind in terms of where it is in terms of clinical trials, but we hope that will also we'll be seeing more results in the coming years. Now, finally, at the bottom of the list, there's a drug called ABT-199 or venetoclax. Now, this is a totally different class of drug that has not been tried in myeloma before. Now, many of the myeloma cells, despite what we do to them in terms of treatment, they're very resistant to dying. And the reason why we think the myeloma cells are so hard to kill, at least one of the reasons, because these cells have a lot of this protein called BCL2, which prevents the process of cell death or apoptosis. So the ABT-199 is designed to the tailor-made molecule that actually kind of decreases the amount of BCL2 protein in the cells. Now, this has been shown to be quite active in patients with chronic lymphocytic leukemia and some lymphomas, but these are the very early trials that are currently being done in myeloma. So one trial is being done looking at the ABT-199 alone, and the other drug is looking at it in combination with bortezomib. Now, some of the initial studies that was done in the lab suggested that patients with myeloma who have a particular type of abnormality called the 11-14 translocation, which happens in about 15% of patients, that those cells may be particularly sensitive to this drug. And in the clinical trial that was the results of which were presented at ASCO and at EHA, in about 30 or so patients who were treated with this, we actually were able to see good responses only in patients who had the translocation 11-14. And they were quite significant responses, deep responses, and we feel that we may have a drug that might work at least in a group of patients quite well. So these are some of the new drugs that are currently going through clinical trials. Many of them are in phase 1-2, but some of them are in phase 3 trials, and we hope would be approved for use for treating myeloma by end of this year or early next year, especially the monoclonal antibody daratumumab and the ixazomib, which is the oral proteasome inhibitor. So I'll stop there and hand this back to Anne.
Thanks so much, Dr. Kumar. And before we move on to the Q&A session, which I know you're all eagerly awaiting, I want to reinforce a few points that Dr. Kumar mentioned. First, Panobinostat or Feradak, it's the newest treatment approved just earlier this year in combination with Velcade and dexamethasone for relapsed refractory patients. And certainly the data showed enough promise for it to get that FDA approval. And now there are a number of ongoing studies that you heard about trying to figure out the right combination to get the best efficacy while balancing the toxicity. So certainly that's a drug to keep an eye on, particularly if you are in that relapsed refractory population. And as we start to refine how it's used, it probably will be a significant player in the treatment of the disease. And then the area that's really emerging, as you heard about, are the antibodies. Elotuzumab and daratumumab were the two that had data presented at this meeting showing incredible response rates in different populations. And one piece I did want to mention, both of those drugs are available via expanded access programs. So if you're a patient who really doesn't have many options left, I encourage you, talk to your doctor, visit myelomatrials.org. You may be able to get access to one of those through the expanded access program. We at the MMRF are working directly with Janssen on the daratumumab one, and you may have seen the announcement just last week about that expanded access program. We're really proud to say as well that those early trials that you heard mention of both Panobinostat and elotuzumab were conducted through the MMRC. And then finally, as you heard from Dr. Kumar, it really is perhaps the most robust pipeline in multiple myeloma ever. Certainly in all of my 13 years here at the organization, I've never seen anything like it, from oral proteasome inhibitors so that patients aren't having to go to the cancer center once or twice a week to get proteasome inhibitors, which are such an important part of therapy, to new classes of drugs like the HDAC inhibitors, BCL2 inhibitors, and there's probably 10 to 12 other classes that just didn't have data presented at this meeting. The immune therapies like the antibodies and the CAR-T approach, which is very early but certainly showing some promise. And then finally, there were no data presented at the meeting around drugs for specific patient populations who have certain genomic alterations, such as deletion of 17p or BRAF. But I've seen in the Q&A that are coming in through the web that there are a lot of questions around these types of populations, so I know that we'll get into some of those details in the Q&A, and we within the MMRC will be opening trials in those specific populations later this year, so stay tuned. So now it really is time for the question and answer session. As I mentioned, there are a number of questions already through the web, so thank you for submitting those. We'll start with those, but those on the phone, you'll also have the opportunity to ask questions. We just ask that you keep your questions general in nature and not specific to your situation, just so the faculty can answer the questions most appropriately and help everyone on the line. So I'll start with the first question, and this is one that really wasn't addressed during these meetings, but I know is on a lot of patients' minds. Thoughts on stem cell transplants, allogeneic stem cell transplants, particularly with a matched unrelated donor.
So allogeneic stem cell transplants, that is transplants from another person, not using your own cells, have been around, well, since the 70s when I first started doing them, but for myeloma perhaps since the late 80s, early 90s. There's no question that that procedure can, in rare circumstances, result in very long-term control of disease, perhaps even cure, but the complications of that kind of transplant with something called graft versus host disease and an increased mortality attached to that kind of a procedure have still made it an experimental procedure, and I would never recommend doing this unless it's part of a research protocol, and perhaps after all other options have been tried. It's really not something we at UCSF consider to be a frontline approach. Perhaps Dr. Kumar can comment.
I completely agree. I mean, there are a lot of patients who have been treated with allogeneic stem cell transplant over the years, and there have been clinical trials that have been done as well. I mean, so far the allogeneic stem cell transplant have not shown an improvement over autologous stem cell transplant in any of the clinical trials. Having said that, there are clearly patients with high-risk myeloma who we feel there might be a role, given the fact that the allogeneic stem cell transplant provides kind of continued immunotherapy in a way. But I think that has to be done in the context of a clinical trial to the extent possible, because we really need to continue to learn more about, and especially as to who would benefit the most, given the significant side effects that can be associated with it.
And then, as I mentioned earlier, there are a number of questions coming through around specific population based on genomic alterations. You know, deletion 1q, deletion 17p, deletion 13, translocation 414. Can you comment on how these factor into treatment decisions, and also if there were any sub-analyses of the trials discussed looking at these higher risk populations?
You know, the chromosomal abnormalities clearly give us a sense of how the myeloma will behave during the course of the disease. The 17p in particular has been associated with a very short duration of responses to most of the treatments we have, and often associated with myeloma that present outside of the bone marrow, so in organs or as plasma cell leukemia and so forth. Now, the studies that have probably the only one thing that has clearly shown benefit for patients with deletion 17p in the clinical trials that we have done so far has been sub-analysis from a couple of studies done in Netherlands, a HOVON study. In those studies, it seemed like patients who have deletion 17p, if they are getting bortezomib-based therapies in the beginning as well as after the transplant until the disease comes back, that clearly seems to benefit these patients. There was some data from double transplants versus single transplants from the Italian group, which again suggested that maybe patients with deletion 17p and some of the 414 type of abnormalities may derive some benefit. We are trying to develop some clinical trials within MMRC, which is going to be looking at some novel drugs which specifically target cells that are deficient in or have the deletion 17p, to see if that can help us make the existing drugs work better. In addition, like the 414 abnormality or the translocation 414, translocation 1416 and 1420, they have also been associated with less than optimum results with the current treatments. And those patients in particular appear to benefit from the proteasome inhibitors. And we have quite a bit of data with bortezomib and some of the data even from the carfilzomib trials that Dr. Wolf talked about. The subgroups, it seems to be benefiting as well.
I would agree with that. I would also point out that I think we have pretty good evidence that for the 414 translocation that bortezomib is favored, especially in a maintenance setting. And there's limited data, but early data, that for the 17p deletion patients, that if after a transplant, for example, multiple drugs are used, for example, a proteasome inhibitor and an IMiD like lenalidomide, these patients may do better than if they're only treated with a single agent. But that's very preliminary.
And there are a few questions around elotuzumab, one asking about the different combinations, or just, I think, clarifying that the study presented, Eloquent, was with RevDex. But if you could comment a little further, Shaji or Jeff, on side effects and also the best populations you think who are patients who may be candidates for elotuzumab.
So the elotuzumab, it seems to be pretty well tolerated in terms of the side effects. These patients, especially in that trial, there are patients who have been on it for several years now, especially the patients from the early clinical trials. And the advantage is over time we are able to give those monoclonal antibodies in shorter and shorter duration of time, and this does make it a little easier. Now, the combination that was presented at ASCO, that is the combination with Lenalidomide Dexamethasone, and that clearly seems to improve the efficacy that we typically associate with the Revlimid and the Dexamethasone. Other combinations, especially in combination with bortezomib, those trials are currently ongoing, and that also seems to be promising, at least based on the initial results. And as we certainly have to have larger, more definitive trials to see if that would play a role there too. I think the best thing about monoclonal antibodies, similar to elotuzumab and others, is that they don't have some of those blood count toxicities that we associate with other drugs. So it makes it much more easy for this drug to be combined with some of the things that we typically use in myeloma today.
I agree.
Okay, and a couple of questions around Kyprolis, and I'd say somewhat relate to the Jim Berenson's Champion trial, which I think there was a poster presented at ASCO. If you could comment on the Kyprolis once a week versus twice a week, and then if a patient has been, I guess it could either be through the Champion trial or just hypothetically on Kyprolis really any therapy for multiple years in a complete remission, how long should they stay on treatment?
Wow, those are two difficult questions. I'll try to take them. In terms of carfilzomib once a week versus twice a week, what we know is that as we bring drugs to the clinic, that is, as they get approved by the FDA, often we're not really finished studying these drugs, and the more and more pressure to get these drugs out there and make them available means that we certainly don't know everything we need to know. For example, with bortezomib, administering it intravenously was much more toxic, and we now know that giving it subcutaneously is better. We also learned with bortezomib that we can give it once a week instead of twice a week. And I think the same kind of thing is going to happen with carfilzomib. That is, because of preclinical data that is before it was ever tested in humans, it was tested twice weekly, and it's quite possible that once a week is sufficient. And we may have to increase the dose, as Dr. Berenson did. We've already seen that we can increase the dose with better results. In a number of the studies, that KRD study that I showed you was a higher dose, and the double dose carfilzomib I showed you is also a higher dose. So I think in the future, and this is my guess, and maybe Dr. Kumar can comment too, I think we're going to find that once a week carfilzomib with a higher dose will be as good, but we don't have the final information for that. The other question is, how long is long enough is really a very, very difficult question. That is, most of the studies using maintenance therapy, for example, are, say, lenalidomide until relapse, which could be forever, we hope. Can you imagine somebody taking it for 20 years? Not really. So I think we need better markers for when we're done, actually, and hopefully with the new measurements of minimal residual disease, where we can measure, as I mentioned, down to, say, 1 malignant cell in a million, perhaps we can actually identify those patients who are done with therapy, if you will.
One of the challenges that we face, as we have more effective drugs and we are able to get better control of the disease, it's a good problem, bad problem. Good problem in the sense we are able to get to places where we could not before. The bad problem is we still have a lot to learn in terms of how long we keep people on, because all these drugs do have tangible toxicities as well.
And here's another, somewhat challenging question. If a patient achieves a stringent CR following induction therapy before a planned autologous stem cell transplant, do you feel that there's still benefit to going on with the transplant at that time?
Dr. Wolf already kind of touched upon the fact that the clinical trials that have been done more recently still seems to suggest that transplant is an important part of the treatment of myeloma at this point, even with the new drugs. And maybe as we have more and more new drugs, that may change in the future. But assuming that the transplant has a role to play in the disease, the question that always comes up is, if you're doing so well with whatever you got started on, and that is more and more so with the new drugs and new combinations, does it matter that you actually go to transplant directly, or should we just think about doing the transplant as your second line of treatment? And I think, more and more, whenever we have asked this question, it always seems that it doesn't really matter whether we use in the beginning or whether we use it subsequently. Before the new drugs came along, the French did a trial asking the question head-to-head. Half the people got transplant after 4 months of treatment, and the other half got transplant after their myeloma started coming back. No difference in terms of the overall survival. Since then, there have been several single institution studies that have looked at that question in the context of the new drugs, and the answer seems to be the same. But I think the most definitive answer probably will come from the trial that has been done in Europe and in US, where patients are getting these new drugs like the Velcade, Revlimid, Dexamethasone combination, and then they are getting transplant early or late. But I think at this point, just specifically coming to the question of, if somebody is in a stringent complete response, would transplant have a role to play? I think the key thing is it also has to take into account the patient preferences. If they are thinking, okay, I don't want to be on continuous treatment with these combinations of multiple drugs, then I think the transplant may be a good path. Do the transplant and may or may not stay on some kind of maintenance subsequently. But if you're thinking, I'm doing so great, I don't want to go through a high dose of chemotherapy and all the side effects, I just want to collect my stem cells and keep it in store for future. I think that is an appropriate decision as well based on what we know so far.
So I'll just add to that. I think I agree with Dr. Kumar and everything he said. What we need to do as the people doing research in myeloma is try to identify those patients who really don't need to go on to transplant. I don't think we're there yet. That is, just because the big studies say that the majority of people benefit doesn't mean that an individual benefits. And we need to begin individualizing our therapy, and perhaps using technologies like the MRD testing will allow us to do that.
There are a couple of questions about, when patients relapse. And if you relapse, can you go back to a therapy that you'd received earlier in a new combination? Or if you relapse on, say, Revlimid maintenance, would you just add another drug, or would you switch to an entirely new regimen?
In general, if somebody relapses while on a drug, I stop that drug. I don't believe there's benefit even adding another drug, except in rare circumstances where we think another drug may potentiate it, but that's not as common. But most of the time we switch drugs. In terms of going back, let's say you had a drug 5 years ago and now you're running out of other drugs, you're relapsing. Can you go back to that drug you had 5 years ago? Well, clearly you can if you didn't really progress on that drug. And in some cases, you can go back and reuse a drug after it's been many years, because perhaps the new clone that's growing out and being mostly the problem is, again, sensitive to the original drug. That's not in every case, though, and you just have to take a chance. Every time we switch drugs, it's a mini experiment. Shaji?
I completely agree with you. I think it's hard to know if you just add something to it, whether it's really playing any role or just contributing to more side effects. So I would always prefer to try and switch to a different class of drug, and maybe even if you're thinking about having to combine the same class of drug, maybe a different drug from the same class, such as using pomalidomide in somebody who is relapsing on Revlimid.
And another, along the same veins in terms of treating relapse, thoughts on a second transplant after relapsing on several lines of therapy?
I think that is one of the things that is increasingly getting the attention, for two reasons. One is stem cell transplant. We know it continues to retain its efficacy. The high-dose chemotherapy will continue to be efficacious. And this is particularly true in patients who got a really good response from the first transplant. So if you had one transplant and you had 2+ years that your myeloma actually stayed away, I think it tells us that the myeloma cells are really sensitive to this approach, and we certainly can consider it again. The second area where I think it's increasingly being used is if somebody, let's say, had 4 or 5 different types of treatments. And what can happen with some of these treatments is they can have a cumulative effect on the blood counts. And now you get to a point where your blood counts are so low that you are unable to get some of these new drugs. And that situation, sometimes we take patients to a second autologous stem cell transplant using the cells that have been banked from before to try and control the disease, but at the same time also get the bone marrow into a better shape so that they can actually get started on new treatments. And there are actually clinical trials that are being designed asking specific questions about the second transplant as to what type of chemotherapy we need to give, whether we should be giving additional treatment after the second transplant, and whether we should be using maintenance after the second transplant.
I fully agree with Dr. Kumar. I mean, take the extreme situation, and I have patients like this, I'm sure Shaji does too, where a patient had a first transplant and did not relapse for 10 years and is now relapsing. Why not do it again? It seems obvious. On the other hand, if somebody has only had a transplant and their disease has come back again in 6 months, you really wouldn't want to put that patient through a second transplant because at best they're going to get maybe 3 or 4 months and spend those months just recovering from the transplant. So I think 2+ years is what most of us in the field tend to recognize as a break point where we would consider another transplant down the road.
And a question a little bit different from some of the previous ones, or amalgamation of questions. In terms of helping patients monitor progress, can you comment, these were a few that were provided on, which tests to watch and how often? Some that were mentioned are PET scan, kappa-free light chain, and M-spike, but feel free to add others as well.
Everybody's disease is somewhat different. That is, not all myelomas are made the same. There are different what we call phenotypes. And so even within the blood testing that we do, where we look for either a M protein in the protein electrophoresis or the light chains for some patients who have light chain only disease, or just measuring the immunoglobulins, everybody's slightly different, so their physician can kind of decide which is the best to follow for them. You obviously can do that every month or two. You can't do PET scanning or MRIs every month or two, and I tend to reserve imaging studies for points where I'm making a decision. That is, if I have somebody who's been in remission for years and now their proteins are going up just a little bit, I might do a PET scan to see if the disease is coming back in the bones. But I don't do the PET scan all the time. I pretty much use the blood tests on a monthly or every other month basis. Shaji?
I completely agree with what Dr. Wolf said, and I think the only thing to keep in mind is there are some things that can change as the disease evolves. So somebody could have a M spike, the typical way we look at it with the electrophoresis to start with, and as they go through multiple relapses, sometimes they stop making that monoclonal protein and they only make the free light chains. So there's a change that can happen over time, which might make us start following something different than what we were following at the beginning. Sure. And in a similar way, some of the patients may stop making protein completely, in which case things like PET can be of significant value.
Okay, and one final web question before we head to the phones for a couple of questions as we're approaching the 2 o'clock hour. There are a couple of questions about different types of maintenance alternatives besides Revlimid. Certainly Ixazomib, there's been some data, but then other available drugs like Kyprolis and Pomalyst.
In terms of all these drugs, we have to kind of figure out where exactly are we going to place them in terms of the treatment strategy. As we already heard, Kyprolis is continuing to move forward into the upfront setting where we are going to start seeing more and more of these combinations. And the same thing with Pomalyst, I think, is going to stay mostly in the setting of relapsed disease because, again, a lot of experience with Revlimid in the newly diagnosed setting. And pomalidomide is going to be used more and more in the setting where other patients who have failed or patients in whom the Revlimid have stopped working.
The maintenance is a difficult question. Maintenance studies require huge numbers of patients and long follow-up and hence a lot of money, millions and millions of dollars to do these studies. So only some companies have gotten into that area and their drugs are the ones that have been studied and hence get used. It may be that there are other drugs that can be very well used for maintenance, but it's going to take time to sort that out. And our hope is that studies with the new oral proteasome inhibitor, for example, Ixazomib, will show that that kind of oral maintenance would be helpful. I think maintenance with carfilzomib is cumbersome because it's only intravenous.
I think now we'll take perhaps one, maybe two questions from the phone before we conclude.
Thank you. Our next question from the phone comes from Rona, calling from Canada. Please state your question.
Yes, hello. Basically, I think you answered my question. My sister has deletion 17 and is currently on various regimes. I'm just wondering, would someone like that be eligible for monoclonal antibodies?
Oh, yes. For sure. For sure.
Okay, and that's through an expanded access program, is it?
At the moment, but it may be approved later in the year.
There may be clinical trials you could access as well.
Okay, thank you very much.
And one final question.
Thank you. Our final question comes from Linda, calling from Virginia. Please state your question.
Could CAR T cells replace IVIG?
In no way. They're not in the same league. IVIG is a very general immunoglobulin that may prevent infections in patients who don't otherwise have enough. gamma globulin or immunoglobulins. CAR T-cell is taking a white cell, a lymphocyte, and training it to be a killer to go after cancer. Very, very different. One is very broad-based, doesn't really kill cancer, and the other one is directly aimed at the plasma cell, the malignant cell.
So thank you so much, Dr. Wolf, Dr. Kumar, and everyone on the line and on the computer. This was an incredibly helpful and comprehensive overview of treatments in general for the disease, as well as specific data presented at this year's ASCO and EHA meetings. As I mentioned, your feedback and comments are very important to us as we plan not only these type of programs, but all kinds of educational programs. As I mentioned at the outset, we at the MMRF are so proud to work with all of our collaborators through the MMRC, like Dr. Wolf, Dr. Kumar, and the 18 other centers that we work with, as well as the 90 centers we work with through Compass and the very dedicated companies that not only support programs like this, but are working diligently to bring the entire community new treatments. All of this progress has been made possible through incredibly generous contributions by patients and their families. We at the MMRF, in terms of advancing all of the exciting research and trials that you've heard about, enrolling Compass and taking what we're learning to the clinic so that patients can be matched with treatments that are right for them. All of that is supported by donor funding, and we thank all of those who have been helpful. Moving forward, we still do need the support of the entire community, and there are many ways to become involved. If you visit our website, multiplemyeloma.org, not only can you learn more about the treatments, trials discussed today, but also how you can get involved directly with our work. So thank you again, Dr. Kumar and Dr. Wolf. We all agree that being informed about the disease and treatments is the best way to empower yourself. So everyone, have a wonderful day. Thank you.